back, guys. So today we will be continuing our topic, which is ischemic heart disease. So last topic we had discussed about stable angina, and now in this topic I will be discussing about the other types of angina, which are unstable angina and prinzmetal angina. Okay, so without wasting much time, let's go to our topic proper. So types of angina, one is the stable, unstable, and the third one is the prinzmetal angina. Here we had completed this stable angina. We had learnt about what is the definition of this and what are its risk factors, what is the pathophysiology behind this, the clinical features, and little bit investigation like ECG and treatment part. Now here in this topic, in detail we will discuss about unstable as well as prinzmetal angina. So what is unstable angina? Unstable angina means the patient experiences chest pain even at rest. See, whatever points I am telling, you have to correlate this with this stable angina. In stable angina, the patient experiences pain only during exertion. Whereas in case of unstable angina, the patient will experience chest pain even at rest. Now, what is the pathophysiology behind this? What causes the patient to suffer from chest pain even at rest? We have to see. For that, let me draw a simple diagram. Suppose this is the blood vessel and this is the heart, right? This is the heart. There is occlusion of the blood vessel due to atherosclerosis. Atherosclerosis is the most important cause of ischemic heart disease. Atherosclerosis is blocking the blood vessel. Now, you would have learnt in atherosclerosis what are the 4 complications which is given in Robbins. In Robbins, I am talking about Robbins. In Robbins, 4 complications of atherosclerosis are given. One is stenosis. The second one is thrombosis. The atherosclerotic plaque ruptures leading to thrombosis. And the third complication is embolus formation. And the final complication is the aneurysm formation. We will deal with atherosclerosis and its complication when we discuss vascular pathology, right? Now just remember, suppose this is the atherosclerotic plaque which is occluding the blood vessel. So just remember here, there are 2 types of plaques, atherosclerotic plaques. One is the invulnerable plaque and the other one is vulnerable plaque. There are 2 types of plaque. Invulnerable plaques are the stable plaques. That means it has a thick fibrous cap which prevents it from getting ruptured. Whereas in case of vulnerable plaque, the fibrous cap will be very, very thin. So it can get ruptured easily. Okay. Suppose the patient is very unfortunate and he has this unstable plaque, that is the vulnerable plaque, and due to some one way or the other it gets ruptured. What happens? If it gets ruptured, the subendothelial collagen of the blood vessel gets exposed and that will activate platelets. So platelets get activated, general pathology topic. So platelets get activated, it leads to adhesion, aggregation and forming a thrombus. Finally, it will form a thrombus. So thrombosis occurs. Now this thrombosis will occlude the vessel submaximally. That means incomplete occlusion. A very little narrow lumen will be present through which the blood will flow, right? And this blood is not enough to satisfy the demand of the heart even at rest. That's why the patient experiences chest pain even when he is at rest. Got it? So what happens is, as the blood vessel gets occluded by the thrombus, flow gets restricted a lot. Blood flow is restricted a lot and very less amount of blood reaches the heart, which cannot satisfy the cardiac myocytes, right? So what happens? The patient experiences chest pain even at rest. So this is the pathophysiology behind unstable angina. So there is an atherosclerotic plaque which should be vulnerable. If it is invulnerable, it will not get ruptured easily, right? And this vulnerable plaque, if ruptures, that leads to thrombosis due to platelet aggregation, and that leads to occlusion of the artery submaximally. That is incomplete occlusion. The whole artery is not blocked. If whole artery is blocked, then it will become myocardial infarction. So the difference between this and myocardial infarction is that here the occlusion of artery occurs submaximally. That means incomplete occlusion, very little lumen is present through which the blood can flow. Okay. Now we have seen the pathophysiology part, and it is a reversible injury. that is cellular swelling occurs. The morphological feature of reversible injury as per Robbins is the cellular swelling. And what is the morphological feature of irreversible injury? That is in myocardial infarction we will read that is membrane damage. Cell membrane damage will occur, mitochondrial damage will occur. These are all the features of irreversible injury you should know. Okay. Now coming to the ECG finding. As you know, ECG finding will be again subendocardial ischemia occurs. As the subendocardial ischemia occurs here also, ST segment depression will occur. So stable angina and unstable angina, the ECG finding will be almost same. Now coming to the treatment part, again we have to give nitroglycerin. How it will act? It will act via getting activated to nitric oxide in the body, and this will activate guanylate cyclase enzyme, then cyclic GMP gets activated, and following which relaxation of blood vessels occur. And one more thing you have to know is unstable angina can progress to myocardial infarction in future if timely intervention is not given. If timely intervention is not given, if the treatment is not given promptly, then he may land up in myocardial infarction. So it's like a sequence. Initially the patient may have stable angina which have progressed to unstable angina, and following which he will progress to myocardial infarction. Okay. So we had completed unstable angina. Now coming to the prinzmetal angina. This is a little big topic, you have to concentrate here. Prinzmetal angina means episodic chest pain, that is one point, that occur at any time due to vasospasm. These 3 points you should remember. It is a episodic chest pain. That means the patient can experience chest pain sometimes at rest, or sometimes even during sleep he may experience the chest pain. Okay, and it may occur at any, that is that it may occur at any time. It will be episodic, and it occurs due to vasospasm. Due to the vasospasm, that is vasoconstriction of the coronary arteries, prinzmetal angina occurs. As the pathophysiology behind this is vasospasm, sometimes prinzmetal angina is also called as coronary artery vasospasm, or vasospastic angina, or variant angina, or angina inversa. These are other names. Okay, just remember 2 names. One is the prinzmetal angina, other name is variant angina. That's more than enough. Now what are the risk factors of prinzmetal angina? Here you have alcohol, nicotine, cocaine, etc. And the topic of interest here is sympathomimetics and the parasympathomimetics. See, sympathomimetics, there is epinephrine and dopamine. They will act via alpha receptors and cause the vasoconstriction of blood vessels. Okay, understood. This is concept. This is a simple concept. Now, how the parasympathomimetic like acetylcholine, methacholine can cause vasoconstriction. Generally, we know the parasympathomimetics like the acetylcholine will cause vasodilation, blood vessel dilation will occur. But here, due to some reason which I will be telling a bit later, parasympathomimetics also will cause vasoconstriction. Okay. Now, and the other causes are anti-migraine drugs as the chemotherapeutic drugs. So, this is the pathophysiology behind this. Will know. Suppose this is the epinephrine. Okay, this is the epinephrine, which is a sympathomimetic. It will act via alpha receptors, and it will directly cause vasoconstriction. Okay, so it will cause vasoconstriction. So if you are giving more amount of sympathomimetics, it may cause vasospasm of the coronary arteries. Now, how this parasympathomimetic act? Now, if you know here, the parasympathomimetic like acetylcholine, example, if you take acetylcholine, it will act via endothelial cells. That means it will activate endothelial cells or stimulate the endothelial cells, EC, and the endothelial cells in turn will produce nitric oxide. And you know the function of nitric oxide, it will directly cause, it's a vasodilator. So, vasodilation occurs. And one more thing you have to know, acetylcholine has a direct action. It can directly cause vasoconstriction. But remember, the vasodilator effect of acetylcholine is predominant or very much greater than the vasoconstrictor effect. So generally, if you give acetylcholine, drug will cause vasodilation rather than vasoconstriction in a normal patient. But sometimes there is some injury to the endothelial cells. But if the endothelial cells get damaged, due to one way or the other way, so okay, endothelial dysfunction, you can say like that, then acetylcholine are not able to stimulate this endothelial cells, so nitric oxide will not be produced and the vasodilation effect is lost. And now only this vasoconstrictor, which is a direct effect, that will predominate, leading to vasospasm of coronary artery. Okay, so this is the pathophysiology behind vasospastic angina, how the vasospasm occurs due to sympathomimetics as well as parasympathomimetics. Okay, now as we can see here, see epinephrine that acts via the alpha receptors and it causes the vasoconstriction that leads to variant angina, and acetylcholine, which is a parasympathetic, it stimulates the endothelial cells and it forces it to produce nitric oxide, which is actually a vasodilator, and it also has little vasoconstrictor effect. Now, as the endothelium gets damaged, the vasodilator effect gets lost. So what happens? It gets lost. So vasoconstriction effect predominates, leads to vasospastic angina. Got it? Now pathophysiology over. Now what is the ECG finding? Before ECG finding, it is also reversible injury. That means no necrosis occurs. Now coming to the ECG finding. So to understand this, let me draw this. Suppose this is the blood vessel and this is the heart. Wait a minute. Yeah. Suppose this is the blood vessel and this is the heart. As you know, in prinzmetal angina, coronary artery gets spasm. That means coronary artery undergoes vasospasm that causes the lumen to become very narrow and the blood flow is reduced abnormally. Now what happens is, heart has 3 layers. All the 3 layers of the heart gets compromised. All the 3 layers of the heart get compromised. So what happens? It's a case of transmural ischemia. Now it's not the subendocardial ischemia. Subendocardial ischemia you had seen in stable as well as unstable. Here it's transmural ischemia. Okay, all the 3 layers get compromised. Now in transmural ischemia, the ECG characteristic ECG finding is ST segment elevation. Okay, ST segment elevation. That's what we are seeing here. See here in the first diagram, ST segment is normal. That is isoelectric segment. Whereas in the next diagram, ST segment is elevated. And the ST segment elevation, that is convex upwards. You have the convex upwards, concave upwards that you will read in medicine. Here you just know that ST segment elevation occurs in case of transmural ischemia. Okay. Now going to the treatment part, the same we have to give the nitroglycerin. But remember, nitroglycerin is very much effective in case of stable angina, but in unstable as well as prinzmetal angina, its effect may be variable. It may be little bit reduced because it's a progressing condition. It's little bit severe when compared with the stable angina, right? So nitroglycerin effect will be little bit reduced. And how it acts? You know, it acts via getting activated to nitric oxide, and that will cause the vasodilation. As in prinzmetal angina, the endothelial cells are damaged, so nitric oxide is not able to get produced. So here the nitroglycerin came into effect and it can get converted to nitric oxide, and that leads to vasodilation of the blood vessels. So vasospasm is neutralized and the patient will become free of chest pain. So with this we have concluded our session. Hope you enjoyed this video. Any comments, feedbacks, everything are welcome. You can write it in the comment section. Thanks a lot for being with me. See you in the next lecture.